Hey everyone, welcome back to the Long Haul. I'm here with Dr. Neal Weisbrod this evening. He is a clinical assistant professor at the University of Florida Department of Neurology. A little bit about his training. He went to med school at University of Rochester School of Medicine and Dentistry in Rochester, New York. Went on to complete his residency in neurology there as well. And then he went on to complete a fellowship in hospice and palliative medicine at UCLA in Los Angeles. Dr. Weisbrod, thanks so much for giving us the time and telling us a little bit more about your specialty in palliative medicine.
Yeah, I'm happy to share my story.
Sounds good. First question I have for you is your experience practicing during the pandemic. If you could tell us a little bit about that. When I first started these interviews, it was kind of during the height of the pandemic. So physicians would talk about, getting the vaccine and the importance of that. But if you could touch a little bit on that.
Well, I think that the COVID pandemic at its height probably had a little bit bigger impact on my role on the palliative care service um, because we were getting consulted on a lot of patients who were ill with COVID and had advanced lung disease and poor outcomes, or really sort of in a situation where they were stuck on different forms of life support for their breathing. So I think that was a real challenge to navigate those conversations for multiple reasons. One is because it was particularly difficult to talk with those patients when they're in respiratory distress and they're on BiPAP or they're intubated. Even if they have retained consciousness, it's really hard to speak to them and understand what they're saying back. Um, and then also, I think all of the PPE really creates this barrier in communication that was difficult to overcome. And when you're wearing two masks and a full gown and goggles and everything, it really does kind of separate you from the humanity of the other patient and make it harder to connect at an empathic level. So I think that those were challenges that were somewhat unique to the pandemic. On the neurology side, I think that we were really rallying together with other services, and I know that the medical ICU service and the hospital service were really getting overwhelmed by the number of patients that we're having to deal with. So all different services like neurology, where we admit patients primarily to our service, really we're working to step up and um, be more aggressive about admitting any patients that we felt like we could appropriately care for, even if they are patients that we might not have taken in other circumstances, because it's really part of the teamwork of helping the hospital run as smoothly as possible.
Right. Yeah. And it was, of course, very sudden, and especially in Florida with our high amount of cases. Definitely, I can see that. Thanks for sharing that. Delving into your specialty, if you could tell us what is neurology and what does that entail?
So neurology is the study of the brain and nervous system. And there is an important distinction between neurology and neurosurgery. And neurology is really a focus on the diagnostic and medical management aspects of neurological diseases, whereas neurosurgery is very much a procedural approach to management of neurological diseases. And they often are involved in the diagnostic process for certain diseases as well, but that's less of a focus of their specialty and much more of a focus of neurology. So we work hand in hand with neurosurgeons a lot, but we really tend to be the more first line and diagnosis and management, and tend to collaborate with our neurosurgery colleagues when there's really a surgical approach that's needed for a certain problem. And so the types of diseases that we tend to treat most often are things like strokes, seizures, brain tumors, disorders of neuromuscular weakness. Some of the more common ones are things like myasthenia or Guillain-Barré syndrome that can kind of come on as sudden attacks. And then there's all the neurodegenerative diseases, things like Alzheimer's disease, Parkinson's disease, and there's a really wide array of other diseases that we take care of as a whole in neurology, but essentially any problem of the nervous system.
Gotcha. I actually scribe for a neurologist. He's outpatient. So I see a lot of neuro patients suffering from Alzheimer's and Parkinson's. Inpatient wise, I'm sure you guys see a lot more of a stroke, and what would be some more common ones that are more inpatient?
Well, the inpatient neurology services for a lot of institutions are divided into different teams. So at a tertiary referral center, academic center like UF, we're going to have a stroke specific team. And that includes ischemic strokes where blood clots go to the brain and there's death of brain tissue because of loss of blood flow, but also hemorrhagic strokes where there's bleeding into the brain. And then there's the neuro ICU team or neurologic critical care. And those are neurologists who specialize in critical care medicine and take care of critically ill patients with primarily neurologic diseases. So it might also be a stroke patient, but a stroke patient who is so sick that they need to be intubated or they become medically unstable. And then there's what is often referred to as general neurology or sort of neurohospitalist work, where that tends to be much more things like attacks of multiple sclerosis or uncontrolled seizures. Then we are typically the service who would manage patients who have other diseases like the attacks of weakness and numbness that are a hallmark of Guillain-Barré syndrome. And there's a lot of spinal cord syndromes, for example, if a patient comes in with an inflammation or a sudden disease of the spinal cord, they would usually get seen by more of a general neurology team in the hospital.
Gotcha. I was watching a movie the other day and they kept using neurology and neurosurgery interchangeably. So I'm glad you touched on that. A question I had was neuro-interventionalists. Is that kind of an in-between? Because I know they do some procedures inpatient.
Yeah, they're neurologists who become interventionalists are a rare breed. And there are a fairly small number of programs where that training is offered and a very small number of neurologists who do that. And it's kind of this blurred middle ground between neurosurgery and neurology. Sometimes neurosurgeons do those procedures. At certain institutions, there are neurologists who are procedurally trained that do those procedures, but it is a pretty rare thing.
Gotcha. If you could touch on how many years of training to become a neurologist?
Well, obviously, there's the 4 years of medical school training, but after that, you're going to have typically a combined 4-year neurology residency. And it used to be that you would have a prelim year, first year of internal medicine, and then 3 years of neurology. But really, at this point, that's all together, included in one 4-year program. The first year is much more focused on internal medicine and learning the different medical specialties like cardiology and oncology. But the subsequent 3 years are really almost entirely focused on neurology. And as an adult neurologist, you're going to have just a small amount of time, several months of pediatric neurology training. And then there's a pediatric neurology, which would be a separate path that actually is 2 years of pediatrics and 3 years of neurology for 5 years total. So the 4 years I'm quoting is really for an adult neurology residency.
Gotcha. And of course, you completed a fellowship in palliative medicine. How long was that?
The hospice and palliative medicine fellowship is typically 1 year if you're just doing clinical. There are some 2-year programs where it's a year of clinical training and a year of research. But the UCLA program that I went through was 1 clinical year. In that most neurology fellowships are 1 year. There are many options out there. Um, you can think of things like movement disorders training, stroke training. There's neuromuscular. There's neuroimmunology, which really deals with inflammatory disorders of the central nervous system, like multiple sclerosis. And there's quite a few others, but almost all of them are 1 year. I think the one exception I can think of off the top of my head is neurocritical care. Those are 2 year fellowships generally.
Okay. Next question is, what drew you to medicine, and then what drew you to neurology as a specialty?
Well, I was interested in medicine very early on in life. My family has a very medical background. A lot of the women in my family were nurses, and my father and grandfather were both physicians. So that's kind of was a natural part of the environment. But that really just led me to explore medicine as an option in high school and start to shadow in the emergency department and start to figure out whether that's something I would want to do. And ultimately, what drew me to ultimately pursuing a path in medicine was this blend between science and the humanities and art of medicine. And I think that's a really interesting dynamic where the root of medicine, when we're trying to make decisions, we're trying to make very scientific decisions. But all of that is seen through this lens of every person we interact with being unique and having unique values and preferences. And also, there's so much scientific uncertainty that we have to interpret all of that in a much more artful way. So I think that for people who really love the hard sciences, but are also really interested in human connection and a lot of human interaction in their day-to-day work, I think it does blend those things really well. When it comes to neurology, I think in general, once you get to this level of specialization, when you've like decided you want to do medicine and are trying to figure out what type of medicine you want to do, a huge factor in what you ultimately determine is the best fit is who you work with and identifying role models and people that you just kind of see yourself in their shoes in the future. And so in my medical school training, I worked a lot with Ralph Josephowitz, who's a neurologist at the University of Rochester. He's really a national figure in the neurology education world, is a really wonderful educator. And he really brought just this thought process and this organization to neurology that really fit well for anyone who's interested in education, because you could approach a problem in such a structural and organized way that it really helps to develop and teach critical thinking skills. So I really liked that aspect. And as I started to do more rotations in neurology, I just really liked the people I was working with and identified a lot with them. And the other aspect that most of us really enjoy in neurology that is a big driving factor is the examination. That as a neurologist, the physical exam is still one of the most important things we do in making a diagnosis. And in a world where medicine is leaning more and more on tests and imaging, it is a beautiful thing to be able to lay on hands and just examine a patient and spend time getting their story and examining them and coming up with a very specific diagnosis. So that apprenticeship of learning the exam and how it influences the thought process was also a huge part of it.
Gotcha. Thanks for sharing that. Working in neurology, I definitely saw a lot of that. And like you mentioned, the blend of humanity and, delivering scientific knowledge. I see that especially in a specialty like neurology, where there's such, heightened emotions during the visit and that sort of thing.
Mhm.
Also, the physical exam, when the neurologist does it, and then he shows me the MRI, it's amazing to see the correlation. Even before reviewing imaging, we can tell that this is what we're going to see. So that was a really
Yeah.
good.
It's a really rewarding thing when you listen to a patient's story. They're kind of telling you what type of disease they have. You examine them, you figure out exactly where in the nervous system it is. And then in the perfect world, when it's kind of single problem and we've been able to really pinpoint it, we know exactly what we're going to see on the imaging. And that's really a rewarding thing.
Right. With the same token, what is the most challenging part of your job?
Um, well, I guess there's two types of challenging. When it comes to what is the hardest part about medicine, I think it's all the other things outside of patient care. Um, just the frustrations of a healthcare system that is imperfect, um, the business side of medicine that no matter what in setting you're in, that is always going to be a reality. Um, so there's kind of structural aspects, but in terms of like the most challenging from a scientific perspective, taking care of patients, I think it's just, in my mind, we have gotten to a place in advancing medicine where there is so much chronic disease that it's getting really difficult when people have so many chronic diseases and then they have a new problem. How do you try to sort out all the different things that are changing their body and really try to separate out this one new problem from everything else going on? It's much simpler when you have a healthy person who develops a new problem. Then you can kind of assume that almost everything that's going on is related to this one condition. But when you have someone who has 10, premorbid conditions and they come in with a new complaint, it gets really difficult. And then you add in all the other medications that they might be on. So I think that is from a patient care perspective, the thing that's the most challenging.
You see. Next question is lifestyle. If you could take us through a typical day at work, the hours, perhaps what time you wake up.
Yeah. That is going to vary a lot depending on exactly what you do within neurology and what type of setting you're practicing in. So my response will be very specific to working in an academic center as a clinician educator and doing inpatient neurology. So I typically will have weeks where I'm on a service, and meaning I'm the attending on one of the inpatient services for 7 days at a time. And those weeks are very busy. I am usually waking up between 5 and 5:30 and getting ready and going to work, usually trying to be there around 7, and then working pretty busy through the day until at least 5. Though a lot of the work that you do as you get into the more supervisory roles in medicine, it's not like you're punching a clock. You just have a lot of work that you have to get done within the day. So sometimes I will leave a little bit early and have dinner, but then I still have a lot of work I have to do after that. So it's hard to kind of put it exactly in a certain time window. But I'm probably working between 10 or 11 hours a day for those 7 days that I'm on average. Some weeks are a little less busy and some weeks are more busy. But the flip side of that is that when I'm not on a clinical service, then I'm really doing other activities like education, committees, other academic responsibilities like papers, research, reviews, and those tend to be light weeks. And so I might work a few hours a day, or if I have a day that's really busy with a lot of meetings, I might work 4 to 6 hours one of those days. So it's highly variable.
Gotcha. Yeah, I hear service a lot when interviewing UF physicians. I never heard that term before. So that's the service is kind of like the clinical practice, right? And then when you're off service, you're doing research and, like you said, more admin work.
Yeah, service is kind of traditionally a term that refers to being responsible for one of the clinical hospital teams.
Gotcha.
And there are a few other nuances of it, but that's the main part.
Okay. Next question is, do the types of cases you see vary depending on your setting, like perhaps academic versus hospital versus private practice?
They definitely are going to change. It's hard for me to speak too much to that because I have spent my whole career in academics at big institutions like University of Rochester, UCLA, UF. But I do know from talking to other people and just from the landscape of medicine that generally speaking, if you work in a private practice, especially if it's more in a small town or a more rural setting, then you're going to see a very different patient population. You're going to see often patients who have more straightforward problems, and then occasionally patients with really complex problems. And sometimes those patients then get referred on to a larger center. When we're at a place like UF, you're going to see a big mix because there's the local population who's going to come to UF for all of its needs. But then there's a huge area between South Georgia, the Panhandle, North Florida, even all the way down through South Florida, where patients come far and wide to get their care here. And so you see really complicated patients with really rare diseases as well. And it's all kind of mixed together. And then you also have to consider, are you working for a public institution or a private institution? Public institutions will take care of any patient who shows up at their door, regardless of insurance. Private institutions often pre-screen and make sure that someone has an insurance that they work with before they accept a patient. And so that's going to also affect your socioeconomic mix.
I see. How competitive is it to match into neurology?
I would say neurology is more of a medium level of competitiveness. It's really just going to depend on what type of institution you want to go to. If you're willing to go anywhere for training, then I would say it's not highly competitive. But like pretty much every specialty, when you start to look at the highest reputation programs, then it is going to be very competitive to get into those programs. But it's not like if you think of ophthalmology or dermatology, where a lot of people who apply to try to get into that specialty at all might not match into that specialty and might have to have a backup specialty. That's not where neurology is. But if you want to go to the most desirable programs, then you want to have the best application possible for sure.
Right. And what's the typical compensation for a general neurologist?
That's going to have a really wide range depending on what setting you work in and what type of work you do within neurology. I would say is a very, very rough ballpark. Most neurologists doing most types of work are probably going to be in the $200,000 to $300,000 a year range. But for people who are really senior in leadership or people who are doing neurocritical care, that is a much more highly reimbursed line of neurology. Or for people who work in really high physician need areas, it can be much higher than that. So, it's not unusual if you want to do neurology and you're willing to go anywhere, and there's a hospital in North Dakota that really needs a neurologist, for them to pay in the $400,000 to $500,000 range. So there's a huge range depending on big cities like Boston tend to pay lower. So you have to take all those variables into account.
Gotcha. I kind of had a question on my mind. I've been reading this book. It's called Being Mortal. It's essentially on like palliative medicine and the shortage of physicians we have right now. So I read this article this morning that we have around like an 18,000 physician shortage for palliative care. And I saw one of the potential solutions is like ARNPs being able to practice independently, or something that I thought of that you could perhaps touch on is, do you think it's possible for our PCPs to get like some sort of training so that they can care for these patients, or if you had any just any thoughts on that?
Yeah, there's a massive shortage of pretty much all healthcare workers. And that is physicians, that is mid-level providers like nurse practitioners and PAs, that's nurses. And it's only going to get harder with an aging population and with a population with a growing number of chronic illnesses. So I don't know that there's one specific area within medicine that I'm feeling that impact more. There's a huge shortage of primary care doctors too these days. So I do think it's very important for everyone to have a basic training in things like palliative care, because at the end of the day, most of palliative care is just really good doctoring principles. It's how do you communicate with people? How do you elicit what their wishes are? And how do you make sure that you're improving their quality of life as much as possible, regardless of what other treatment they're getting? And those are things that every doctor should want to do. And so some amount of that training is really core to all physician training. But I do think we're going to have to partner extensively with our mid-level providers and also within the realm of specialty versus primary care to partner with primary care physicians to try to have everyone working as efficiently as they can and taking care of all the things that can be within their scope of practice. Certainly, when a primary care physician is comfortable taking care of a wider scope, it's going to reduce the amount of specialty referrals. But I think it's definitely going to be more structural, widespread changes that are necessary for our healthcare system to reach a point where there's not a shortage of healthcare professionals.
I see. Last question for you, Dr. Weisbrod, is what advice do you have for someone who wants to go into medicine or neurology, kind of in general, who wants to go into medicine?
Well, I think it's important to know the long-term sort of prospects that you're getting into. And I love my career. I love what I do. I wouldn't go back and make a different choice. But it is a very hard road to get through medical training. Medical school is a very challenging time. Residency is an extremely challenging time. And that's just what it takes to get training in a compressed amount of time. Medical school and residency could be a lot easier if we wanted medical school to take 8 years and residency to take 10 years, but that doesn't really work for our society and no one wants to do that either. So if you try to bring people up to speed, get as much knowledge and experience in as possible, it is a very difficult set of years. But the reward on the other side is, one, you have ultimate job security, that as a physician, you really never have to worry about whether you're going to have a job or not. And then there's so much joy and reward that comes from helping people through some of the most vulnerable times in their lives. And I think if you just kind of understand that very big picture view of what you're getting yourself into, that it is going to be very challenging and you're going to need to tap into your support system and make it through the challenges of medical school and residency, and you're really buying into this lifelong practice of medicine that is extremely rewarding, then that's kind of the main thing I would want people to consider before committing.
Thanks for sharing that. Our channel is actually called The Long Haul, so you kind of shed some perspective on why it's called that and how the name came to be. So
yeah, absolutely.
Really appreciate you coming on, and I had a great time speaking with you. So thank you so much for that conversation.
It's a pleasure to talk with you, and I wish you the best in your future, and I hope that this discussion can help shed a little bit of light for others.
Absolutely. Thanks again. Take care.